All right. Good morning, good afternoon, and good evening. Welcome down the security rabbit hole to yet another edition of the Down the Security Rabbit Hole podcast. Friends, colleagues, friends, countrymen, lend me your ears. Anybody remember that one? No, Robin Hood Men in Tights. Great movie. Really weird scene, but really great movie. James, how you doing, man?
I'm doing well today. How are you doing?
I'm good. I'm fully caffeinated. It's a little dreary outside. Like
Yeah,
autumn
same
just showed
here.
up in Atlanta. That's not cool.
Yeah,
We're
finally
waiting
get
for
some
some more
rain.
summer. I think this is now a perfect time to go through and have a discussion on this topic. We've got Dan Dodson is going to talk to a little bit of wow. Let's try that again. Oh, maybe the caffeine's working faster on the brain than the mouth. All right. Dan's going to talk to us about healthcare security. That was a mouthful. Dan, welcome to the show.
Yeah, thanks for having me. It's a little gloomy in Dallas as well, so I do think autumn is here. So,
The last time I was in Dallas, I think it was two weeks ago. I think it was like
oh yeah,
195 degrees. I went for a run at the Star there, and I got out at about 7:30. By the time I came back about 8:30, it was already unbearable and hard to breathe. So y'all can keep that weather.
yeah. It's in the 60s today, but you're right. It's like 11 p.m. and still hot. So,
Yeah,
we're
yeah.
glad
So,
fall's
all
here.
right, tell us a little about who you are and what you do, Dan.
Yeah, absolutely. Dan Dodson, I'm the CEO of Fortified Health Security, and we work really hard to help protect patient information and allow hospitals and healthcare organizations to continue to operate by putting in cybersecurity safeguards. And so
Okay.
that's what we do.
All right, cool. So listen, I think this is a good time to ask this question, but because I've seen the just recently got announced that the MGM breach is being somewhere around $100 million. All right, uh, I don't imagine any hospital has that kind of money. So when it comes to the state, we'll start in a very familiar place. When it comes to the state of healthcare information security, where are we?
Um, we're in the early innings, I would say. We got a lot of work to do, quite frankly. And I
Okay.
think that the interesting dynamic in healthcare is, if there's a successful incident, look, it can disrupt patient care in these communities, right? I mean, the hospitals cannot deliver care without technology today.
Well, we've seen that. We've absolutely
Yeah.
seen evidence of that. Some hospitals and a hospital chain up in my old stomping ground up in Illinois had enough of an issue where they actually closed doors.
Yep. We're seeing closures. We're seeing, weeks of downtime, diverting patients. And there's kind of a second and third level impact in these communities because the other health systems, if it's not a rural hospital, they get overrun with extra patients and stuff like that as well. So it's a complicated mess right now for sure.
How much of the risk when we talk about it, especially if we're talking about hospitals in general, but how much of that risk is billing systems, natural support systems versus, there's always talk when we talk about hospitals, of all the equipment like this. I can't do a CT scan. I can't do an X-ray. I can't do that,
That's a
right?
good
Because
question.
all this stuff got thrown on the network. How much do we actually see that stuff going down versus, hey, we can't accept people because our billing system and our registration system is actually down?
Yeah, it's interesting. So there's been that technology has kind of converged into one. And so your billing and your clinical systems, your EHR is really like a unified system today. So when the servers in the network get impacted, the doctors and clinicians, it's both, James. They can't check you in and they can't look at your records and they can't deliver care. Right. And that's what takes them down, completely. And then secondarily, you're seeing like even phone systems, right? Like organizations don't know how to communicate. How do I communicate with docs and nurses and tell them what to do if the phone system's down? I mean, it's kind of all of the above.
Hey, I've been in enough doctors' offices with parents in their 70s, kids in grade school and all that recently that um, I've been to enough of them that still have those big shelves that move, right, with all the records in it, and they're somewhere between that and like the Epics and the whatevers that they use. I just know that one because I used to have people that work there, but like the e health record systems. How much of U.S. healthcare system on a whole, accounting just, I mean, if we take everything, cut it with a broad swath, how much of it is converted to EHR?
I think on the hospital and health system side, you're greater than 98%.
Oh, okay.
On
Not
the
expecting that.
yeah, so if you think there was a huge legislation move in 2009 with R and high tech under Obama that basically had a carrot and stick to digitize healthcare. The challenge though was cyber was not an element of that.
No, that's a shock.
And so, right, exactly. And it's always the afterthought. And so now on the doctor's office, to your point, it's probably less penetrated, right? So like if you're an independent physician or something like that, you know, you may still be doing, you know, some paper charting as well as, you know, some billing typically in the system.
Let's start on the side that can actually afford to talk about this. That is the hospital network, healthcare network, the big conglomerates. I have seen evidence of tightening budget, buying restrictions, in some cases, even layoffs of IT staff. That can't possibly be good for the situation we're talking about, which is security. Are you seeing, I guess, what are you seeing? Because you would interact with these folks more than I do. What are you seeing happening in that industry?
Yeah, the first thing that I would say is, you know, these organizations have enterprise cybersecurity risks on SMB budgets. Like even if you're a multi-billion-dollar health system, you buy like an SMB. You structure your team like an SMB, right? So a $1 billion commercial business would have a large cybersecurity team, would spend a significant amount of money on IT, those types of things. A $1 billion hospital doesn't do that. So the operating model is different.
Why?
Well, because for a couple of reasons. One is healthcare in general operates on grocery store margins, right? Super low margins. Most of them are negative, even the big guys. You know, the recent trend is some of these health systems are losing money for the first time ever, or the first time in 50 years. And so it just kind of trickles down, right? And so
Okay. That's baffling me. Dan, that baffles me given how much you pay for a stupid doctor's visit.
Oh, it's
Or an
incredible.
aspirin.
Yeah, considering it's what 17-18% of our GDP, right? I mean, it's not like we're not spending money in the collective healthcare ecosystem, but yeah, it creates a tough environment for sure.
So you've got an organization that runs on razor thin margins. I'm gonna give the benefit of the doubt and say on razor thin margins on IT. So, but isn't that where all the innovation right now is happening? Right, everything that we're innovating with, advanced techniques for care, patient care within everything from surgeries to how we get records across to how we have specialists in other parts of the world able to review somebody's MRI, CT scan, whatever. Like that's where the innovation is. What the hell?
Yeah. You're spot on. That is where the innovation is coming. And I think that was accelerated through COVID, right?
Yeah.
We saw the spike in you know, virtual visits. We saw a spike in people working from home. I mean, you know, healthcare is oftentimes a dinosaur in the way that it thinks through, you know, working environments, those types of things. I mean, before COVID, every IT worker went to the hospital or the IT building every day. It wasn't like other industries where remote was starting to etch in there. And so, yeah, you're right. It's not only innovation, you know, from a medical perspective, but also from the way that they're executing the day-to-day elements of their business. And I think we're seeing cyber take more and more forefront of conversations. When you think about what moves investment dollars in healthcare, it's really three primary things: patient, you know, safety, engagement, those types of things; clinical, if you will; revenue, right? So if it's going to impact revenue, and then regulatory, right? And cyber is hitting all three of those components, which is elevating the prioritization of cybersecurity within the hospitals.
I think so. If you give me those three, regulatory is the stick, right? That's the one that all else fails, the entire cybersecurity industry as a whole, James, I think we've talked this one to death. The entire cybersecurity industry as a whole, that's what, like, if everything else fails, we go, but the regulations, and sometimes we get some small chunk, or the lawyers figure out how to do it and sort of like half do it and then pretend like we did it and hopefully get away with it. The revenue part blows my mind because I get it. And we're not here to debate the U.S. healthcare system here. And thank God, because I don't have enough booze. It's too early in the morning.
We don't have enough time.
Or the time. And I don't want to get that angry at this time of day. But when you look at, okay, fine, revenue. When you are out of commission, and like the whether you're a casino, whether you're a bank, whether you're the local train, commuter rail, whether you're a gas station, every moment you cannot transact and do the thing that your business does, you lose money. In healthcare, you have the added bonus, and I say bonus with a grimace, of potentially hurting people, like impacting people's lives in a horrible way. How do we not hold people accountable for like, I don't know, maybe that's the wrong thing I'm thinking of, but like when you go, oh, well, that's going to impact revenue, you're like, yeah, but also people's lives. Like the kinds of people that take those jobs shouldn't be worried about, is this going to be good for revenue? And only they should be thinking, like, don't you take that kind of a job in the healthcare system to do better, like to, impact people's lives, hurdle us towards a better society, all that. Like, that's what I think. And so, like, sitting there scrutinizing over budget and saying, well, I don't know, we can make an extra, 5 cents a share if we just roll that old AV for another year. And obviously, I think patient care, quality of care should be, like, if that's not what you're thinking about, you're in the wrong industry.
Yeah, and I would say by and large, most of the people that are in healthcare are there for the mission and understand it. And I think the push and pull is not against, making profit versus investing in cybersecurity. It's adding another service line of clinical performance. It's buying a CT machine. It's not like the conversations that I'm having. It's not like, oh, we need to make money, so let's cut cyber. It's like, oh, we need to expand our care coordination. We need to outreach in the community because we're operating. So I think they're thinking about it rationally. And I would say that, look, in the last 2 years, maybe 24 months, we're starting to see, and you named one, like big downtimes, right?
Yeah.
Prior to that, we were seeing some data stolen, which we don't want. Nobody wants that to happen, but we weren't seeing massive disruptions to care, which we're seeing now.
Fair enough.
So that's what's escalating it, right?
How's that? How's that changing with like cybersecurity, like cyber insurance coming in? Like we see cyber insurance drive a lot of industries into like, hey, you can't run at an SMB level. You got to actually step it up. Do hospitals see that same thing? Because I got to imagine cyber insurance coming in, like the cost of you closed your doors, people didn't get in, like maybe lives were lost or serious injury. The lawsuits that are coming from that, does that still fall under like, hey, you made a bad security decision? And you know what I mean? Like, is that driving that any, or do they even struggle to get insurance?
They do struggle to get insurance. And I think that the big thing is, look, by and large, premiums are doubled while coverage is 50%. We're seeing a lot of carriers, limit the amount per breach, as an example. I think the biggest difference, which I'm fearful of, is, used to you could get cyber insurance, fill out a two pages of paper. Easy for me to say. I need some more of that caffeine.
Yeah, see.
But now it's like 50 pages, right? And they're getting very detailed on what are you doing with their cybersecurity, right? And then they're binding the insurance, right? And then if you have an incident, they're going to pull out all the things that you said that you were doing that are in that policy, that are bound in that. And if you found out that you weren't doing it, you actually aren't going to get covered. You're going to get clawback during claim review, right? So I think that's a challenge overarching. I think the benefit of it is, though, the cyber insurers, James, to your point, are being very prescriptive about what you have to do in order to get the insurance. So MFA was of a very hot button last year, making sure you have MFA. This year, they're talking a lot about, next gen AV and EDR and MDR and those types of things. And so they're getting more prescriptive about what they want in order to cover it.
Okay. This brings me to a topic I'm fairly passionate about. So, but first, I want to go back a little bit because you mentioned the push and pull of budget between new services, new capabilities, right? Reaching more patients faster, better. That is part and parcel with cyber. You cannot decouple, in my mind, after almost 25 years in this industry. I can no longer decouple saying I can reach more people, I can do better patient care, I can do X, Y, and Z, but cyber is a separate thing. I just, those two, that does not work for me in any mental model. Are you seeing that? Like, are they not coupling those together?
Yeah, I think it's a trend that I would say more and more are, right? I think, cyber used to be buried in the basement of IT, so to speak, and kind of second or third level thought.
Yeah.
And to your point, you can't put in a big, patient engagement initiative if you don't consider cyber, because all of that good will be undone potentially, right? And so I think we're seeing organizations starting to weave cybersecurity into all the business decisions as part of their strategy.
Okay.
But look, I think we're in the early innings of it, though, right? I mean, compared to other industries, for sure. But that's an opportunity that's growing.
That's interesting. That's one of the things I was concerned about is as we think about how we innovate, how we care for patients better, it's not just about like, oh, protect records, right? This is really about long distance reach. This is about access. And if something breaks and that system is offline, that network is offline, that communication, that call cannot be made, it has serious adverse effects. And you can't go, oh, well, that's an IT problem, because it's not. Like in a lot of businesses, it becomes an IT problem. You're like, oh, IT fix it, right? In this case, it becomes like, well, hell, we all sit on our hands while this patient is, slowly suffering or worse. And that becomes a real sticking point for the way I look at things in that industry.
Is that a issue though of focusing on the wrong thing? Like most organizations, right? You're thinking about data. And so everybody, when you talk about healthcare, you think about the data, like, oh, I don't want my health records, right? So all that focus is, how do I protect the data versus how do I protect the processes and workflows that get somebody in and out of my systems, like in and out of my facilities? Like, do we spend too much time with that stuff of, hey, my focus is on protecting the data. Yes, I did EDR and I did all this stuff, but did I do it to keep my system running so we could still access billing, or just so somebody couldn't access the details in billing?
Yeah, I think that's a great point. And we're seeing a lot more of like incident response planning, business impact analysis, like a lot more of those types of tabletops, exercises, those types of things, James, to make sure that the safeguards that folks are putting in place are actually going to be able to enable the continuity of care, in the hopeful event that doesn't happen. And, but if it does, what can we do about it? I think that's an important element to it for sure.
All right. So let's transition from from where we are here to talking a little bit about, I want to figure out the alignment of cyber to mission, because we're talking about, you said MFA and some other things. A lot of those initiatives in security have actually, and this is from experience, have actually negative impact on not quality of care, but maybe speed of care, and how many times somebody has to go hit a button on a keyboard, or if they have to to get to a computer in an emergency room and it's MFA, that's an extra 2, 3, 5, 10 seconds that patient may not have. So are you seeing the alignment to mission, the alignment of cyber against that? Because I think there is the general, like, let's make things more secure and more safe versus how do we do that with patient care in mind?
Yeah, I think that that's actually an area where health systems, hospitals, health systems have done a decent job. There's a lot of single sign-on. There's a lot of tap and go. There's a lot of badge in, badge out. There's a that refreshes the screen that you need based on the patient that's in there. Like, I think there's actually been some partnership, if you will, between the clinical staff, nurses, docs, etc., and IT and cyber to attack some of those things. It's not perfect. It certainly could be improved. But I think from an IAM kind of access perspective, I think there's been some good progress in that space, actually, relative to that.
Where are the big challenges, right? So what are the big initiatives right now that you're seeing in healthcare? Like, what are the big kids working on? Like, what's the thing or things?
Yeah, well, I think the big boys are thinking about AI, right? I mean, and what does that mean to
everybody?
Yeah, exactly. I think if you step below that and you look at just like cyber macro trends, right? I think that the four things we see the most are just the talent, right? I mean, cyber talent, we don't need to talk. We can talk all day about the shortages globally, but the reality is that just becomes exponentially more difficult for these hospitals because they typically pay less for cyber talent. They typically don't have as big as budget, which means the people aren't working on as cool as tools, if you will, which folks love to do. So that's issue one. Issue two is because of the nature of this, that typically there are exceptions. They have small teams, but those teams are often pulled in multiple different directions. They're also doing networking, they're doing application stuff. And so what ends up happening is which is the challenge, is they struggle with the execution of the fundamentals, the patching, the vulnerability management, the watching of the alerts, those types of things, like the unsexy stuff we all got to do in cyber every day. They struggle on that. And then the third is there's actually been a lot of cyber tools sold to healthcare, right? The problem is that the true understanding that these tools are designed to reduce risk, but the way that you reduce the risk is with people in process. So there's been a lot of like, let's go buy a bunch of shiny boxes, but if we don't operationalize it, if it's not working in concert with my other tools, you have this whole perception gap between the risk you've actually reduced and the risk you think you're going to reduce, right? So that's kind of the third challenge. And then the fourth is just the threat landscape. Like, look, hospitals are not designed to keep up with the threat landscape, right? So those are kind of the four that we see day in and day out that folks are trying to figure out how to tackle.
I was gonna say, from a technology standpoint, I mean, are they typically behind the 8 ball here when you talk about, hey, hospital technology is probably still running stuff 15, 20 years old. I mean, how many times we hear the thing like, hey, we got Windows, 3 out there on some system to be able to run, something, so not only are you stuck with 2 of, that issue, but we've got technology that isn't even supported by most of these new tools. Or how do you integrate it to these tools and find somebody that has expertise to even try to do it? Because how are you going to find somebody who knows how to integrate with Windows 95?
James, I'm gonna piggyback on what you're saying, because yes, that, but I think the biggest challenge in the technology space is, you're right, the ancient IT gear that they have walking around or carting around or just sitting collecting dust is at one level. The threats that are coming at them are at another level, and security's trying to bridge the gap between. And so this is like, you've got old kit that won't take the new path. Listen, I've been on 2 calls in the last month where I heard an IT leader, not the cyber person, but the IT leader in a healthcare capacity, in a network system, whatever you want to call them, say, listen, my biggest problem is that I've got the kind of technology that I have in places that are critical to life support don't take patches anymore.
Yeah.
I can't put my EDR tool on them. I can't segment that part of the network off in any meaningful way because the technology is using protocols and methods that don't conform easily to passing through segmentation like firewalls or whatever. And so you're stuck with, you know, the thing that's everybody's nightmare, right? Protecting old ancient things against modern threats and trying to stitch the talent and tech that you have at your disposal for that. And that is not easy stuff.
And at what point does that switch though from that was security's problem, right? Like, because we approach this from a cybersecurity standpoint, but when you talk about that stuff, that's an IT issue, right? Like that's cybersecurity budget's small. I don't know what IT budget looks like, probably small as well, but that's an IT decision to say, hey, we're not putting forth these programs to upgrade our systems, right? Like, how much does it take to go take a system that's on XP and have to rewrite it so it'll run on 11, right? Like, there's work there, and that's an IT thing, not a cybersecurity thing, even though it directly affects.
Yeah, Dan, I want to ask this because this is the direction I think James and I are both going. How much of that ancient tech that's still out there that we all know is still out there, is it because somebody doesn't want to upgrade, but the upgrade path doesn't exist? Like, there is no new version of something that's not patchable.
Yeah. So the answer is yes to all of that. but I think, there's another dynamic to build on what James was just saying, that there's also clinical engineering. So that's fancy for saying who owns the medical devices, right? Because all of these medical devices are running legacy software to power them, right? Yeah. And so basically what you have is and sometimes the health systems don't even know what technology that's
the worst part,
right? You're right. So now recently the Patch Act just got pushed through, and basically it says that through that FDA approval process, you have to consider cybersecurity. Okay, we won't get into this in a regulatory podcast, but anyways, so that helps to some degree go forward devices. But to go back to your question, you've got literally millions of medical devices in the US from hundreds, if thousands of manufacturers, right? Where we don't necessarily know what's running in that device. If we do want to patch it, we have to find and coordinate, if a patch exists, with the manufacturer so that I don't void the warranty. I mean, this is a complicated problem.
Yeah.
And oh, by the way, a CFO of a hospital is very unlikely to replace a medical device
that's already working.
That's working. Exactly. And there's no end of life. So when you go into a CT machine, it could be 20 years old. Yeah. As long as it's clinically relevant, they're using it. Right. Yeah. And so by the way, that's a $5 million device to replace, not a $5,000 device. So, I mean, it is a complicated issue.
This reminds me of the power gen industry, where end of life is when the thing dies, like physically stops functioning and burns out.
Yeah. Yeah. As long as it's working clinically, they use it.
And, unlike other systems, right? I mean, you look at old systems like COBOL systems, financial industry are like, yeah, we got to get off COBOL because we just can't, like, it's still working, but it can't scale, right? It can't keep up with the demand. Medical devices don't need to, like, and that's it, right? It's a standalone device. Yeah. It doesn't need to scale, right?
That's right.
The only issue that we have going on with it is you connect to the network and we've got potential risk, but it still functions as it did day one of doing what it's supposed to do, performing an X-ray or whatever it is that it's going to do, right? So of course nobody's going to sit there and say, well, let me get rid of this one and get the shiny new one. What did it do? It gave me the same thing, right?
Exactly. Now, what I will tell you is there have been some advances in cyber technologies that effectively can listen to these devices, map them out, and simply put, they look for changes in performance, right? So if I'm a medical device and I always talk to this server and all of a sudden I start talking to that server, it triggers an alert. Could be something, could be nothing. So like there's some kind of technology that's helping to overcome the challenges of IoT, IOMT, those types of things. But it's a challenge for sure.
what's the rate though that like a device like that is getting actually attacked, right, and being shut down? Because it makes me wonder the question, okay, if say we hit the X-ray machine and we modified the settings on it or we did something to it, like how do they recover from that? Like if it's that antiquated, like what's that process look like to try to reflash the ROM on this thing to be able to make it work again? Like, does that brick things
It's
to
down
be like
for a week, James?
like
What
we
happens.
just
It's
broke it
down for a
forever, now
week.
you have to buy it?
Right.
That's probably the right answer, James. You have to go buy a new one. But I would say, look, I think that most of the adversaries are looking for money, right? So they might use it as like an entry point to jump in and try to get in the network and find, hold something ransom, etc. But look, the number one attack vector in healthcare is largely through phishing and those types of things, right? That's their entry point, and that's what they're using to get to the crown jewels, if you will.
So don't open your email on the X-ray machine.
Well, here's the interesting thing, right? Yeah, well, it probably has
simple,
email,
buddy.
James. We wouldn't know because we don't know what's on it. But I'll tell you what's really interesting though is if you think about there's 5,000 people that work at a hospital, and let's say a vast majority of them are clinical in their role. I would say universally across the board, we give people email and internal and external, right? And so like part of what I tell people is I'm like, look, man, this is a cultural challenge because people associate their employment with their email. But do they really need email? Like this is the number one attack vector. Like at some point, how do you balance that? And do you say, hey, you know what? For your business function at the hospital, you don't need to talk to people externally. Maybe you don't need an email.
Well, joking about the open your email on the X-ray machine just made me think about, because I was just joking about that. But if you think about the older systems and the limited capabilities they had, right? Like I talk my vehicles, right? Like you get your older vehicle, man, like it ran on gas and oil and that was it. Like there was no technology. You had to roll your window down yourself, like all that stuff. And now you look, there's a full computer sitting in that thing and I can pull down the weather. I can pull down anything I want.
Computers just happen to drive, James.
Yeah. So like, is that though an increasing risk when we look at the newer systems? Like, hey, I just got rid of my nice old mechanical X-ray machine. I just brought in the new one and it's got this pretty interface that actually lets me view my email, like, because, hey, I need to get email right away when I'm at the machine, or I need to email it to some other thing, right? Like they're full operating systems on here. No longer was it, hey, it's just a little ROM that's got some, some simple commands. Like it's a full-blown system. Like, does that create even more risk than having the dumb system that, doesn't let you do anything? Like push a button and that's it.
Yeah, I think yes. And I also think that you're now taking this, I'll say, smarter device, and then you're hooking it into your system. So it's actually exchanging data versus printing out the old thing, then typing in the result. Like it's all
Data
integrated.
interchange.
So this whole ecosystem is just expanded exponentially.
All right. I'm curious because I want to get this question in before we run out of time. With a lot of the security industry has kind of, I don't know, maybe taken the position that, hey, just install an endpoint product on it, it'll be fine. How much of what you're seeing in terms of threats can't be either detected or blocked with an endpoint EDR tool? Like how much is the network required here? You know what I'm talking about?
I know exactly what you're talking about. I think they're both equally important, to be honest. I really do. I think, look, you got to be running a strong endpoint. There's no question about that. I think monitoring the network is equally as important. I think it's part and parcel to a strong cybersecurity program. You got to do both, would be my recommendation. I think, but I also think what you're seeing is on the tech side, you're seeing the, MDRs or EDRs or XDRs, whatever marketing term we want to put on it, expand their capabilities to be able to do more network, right? Maybe attack the SIM space a little bit, if you will, on the edges and nip at it. But I think you've got to look at the totality of it. And partly because in our world, the medical device stuff we've just been talking about, right? Those are on your network, but you're not putting an agent on those devices, right? Yeah, and so 100%. I've got to be able to look at the totality of the ecosystem and monitor all of it.
And those aren't
Well-
the typical entry point, though, right? I mean,
No, but they're a victim. They'll
right,
be
they're a
victims
victim,
all
but
the same.
if you can put it on the typical endpoint and stop it before it gets to the other victims that are sitting there helplessly, right? Like if I put it on all the systems that have email capability, then if I can stop phishing there, then I'm less concerned, right? Like we can't fix it down there, but we can help slowly mitigate it up here, because in most of these cases, right, like it's the regular systems that are getting ransomware or something like that that's stopping people from coming in. It's not that they trickled down into, I shut down your CT machine.
Except for the fact that you got a contractor that's got to come in and update that CT machine and plugs into your network to do so. Boom.
Yeah, that's right. Exactly.
All right, well, guys, we're up on time. This is, you know what? It's been fun, but it's a little disheartening. Dan, I like the weather today. So this is a bit of a gloomy conversation because the healthcare industry is where general IT was and finance was in like the mid to late 90s. So a quarter century of lag is bad, especially with an aging population that requires more healthcare, more advanced techniques. We're relying more on innovation. And if all that stuff is awesome and it's happening, and then these institutions get blasted with some, jackhole sitting in the basement someplace thinking they can just go ransom hospitals because we know there's no honor among thieves, then you know what? This is a bad situation. Do we could just go back to, making walled fortresses around hospitals? I mean, essentially, or care facilities. Like, there's a lot of work to be done here, Dan.
Yeah, no doubt about that. But we put the good fight in every day and try to work hard to do it. So
that's it. That's what this podcast is all about, getting the good fight out there. So, hey, Dan, thanks for being on the show. I appreciate your time. Yeah, this has been informative. You certainly, you've certainly got some insights.
Yeah, thanks for having me, guys. Really appreciate it. It's been great.
All right, folks, that was it. Thanks for listening. Another episode of the Down to Security Rabbit Hole podcast on healthcare sector security. I suspect we'll probably have a few more episodes on this one, James, because there's a lot to unpack here. There's a lot to unpack here. I want to talk about at some point the patching and revving old technologies and this whole endpoint versus network discussion and blah blah blah, and then maybe some innovation, right? So, oh well. All right. Until next time, for the Down to Security Rabbit Hole podcast, this is Raph signing off. Cueing the music, and off we go. Thanks for listening. We'll catch you guys another time, another place on another Down to Security Rabbit Hole podcast.